Bismillahirrahmanirrahim. Once again, I would like to welcome you all on behalf of the organizing committee of Pakistan Society for the Study of Liver Diseases on the 14th annual meeting, this time being held virtually from Karachi. But having said that, we are not just limited to Karachi. We have participants and speakers ranging from all corners of the globe, and even our local presenters are are in different countries, and they are with us both in spirit and in person. So we formally start our Symposium number 9, which is regarding hepatitis B and hepatitis D. This is going to be chaired by people of esteemed reputation in gastroenterology. To name a few, we have Professor Zagham Abbas, Professor Badr Fayaz Zubairi, Professor Shanil Qadir, Professor Samiullah Sheikh, and Professor Dr. Asad Chaudhry with us. I believe all of you can hear me properly because I'm getting a feedback that my voice is not clear. My voice is still not clear. I think with this we hand over the screen to Professor Wasim Jafri, who is going to talk about occult hepatitis B infection, diagnosis and treatment. Professor Wasim Jafri is a name which does not require any introduction. He's a well-known hepatogastroenterologist in Pakistan and has earned a great name in Pakistan and in the region. After obtaining his initial training in medicine and gastroenterology in the United Kingdom, he was trained in hepatology at University of Miami, Florida. He's also the director of Karachi Training Center of the World Gastroenterology Organization since 2001. Professor Jafri, if you're there, we would like to welcome you. Please take over the mic.
Okay, thank you. As Dr. Saeed has just telephoned me to start, so I'm starting. Thank you very much for allowing me or inviting me to give this presentation. I'm still jet lagged, arrived this afternoon, so hopefully I'll be coherent. So the topic that was given to me was occult HBV infection, diagnosis and treatment, if any. So let's start with it and see what we have in this presentation. So as we all know that hepatitis B affects millions. 2 billion people have been infected, 1 out of 400 million people are chronically infected and seeking help and advice globally. 10 to 30 million will become infected each year, and the figure is not decreasing in certain pockets of the world. An estimated 1 million people die each year from hepatitis B and its complications. And the figure is rather, 1 million could be 1.2 or 0.9 or whatnot, but on an aggregate, lots and lots of people globally perish because of this illness. Approximately 2 people die each minute from hepatitis B. And again, this is an area where, of course, lots of things are in the dark because, there are pockets in the world where, of course, there are more deaths, and then there are other countries and pockets, and they live happily and they don't have that kind of problem. But on an average, one can give that kind of figure. This is a very, very complex virus. It has several antigens, we all know that, and it belongs to the Hepatinavirinae family with, it's a DNA virus as we all know it. It's double-shelled practicals, outer lipoprotein envelope, which we all are very familiar as surface antigen. And initially, when the virus was, told to us by Bloomberg and his magnificent work from New York, we used to call it as Australia antigen. And of course, later, as we identified the virus more and more, it became the surface antigen. There are 7 genotypes, 4 major subtypes. All hepatitis B subtypes share one antigen, which is, extremely lucky. And that's how, in fact, the vaccine got developed and lots of people are protected. It's the A antigenic determinant. Thus, antibodies to the A determinant would provide protection for all subtypes. Let's skip this slide for the constraints of time, but we all know that, you know, the surface antigen is the outer covering, and then of course we have the core antigen and the E antigen of the virus, which of course also belongs to the core. The serology is interesting for general audience. Of course, the group that we have assembled here may not be all, because they're all very, very familiar with the serology, and hence we can skip this part as well. The outcomes from hepatitis B infection is extremely important to know, because the age group that we all belong to certainly is one that you know, is a great from hepatitis B point of view, because once infected beyond the age of 15, certainly there is so much of self-immunity that almost 90% or overwhelmingly everybody gets, you know, his hepatitis B taken care of through their own defenses. Whereas if the infection happened in the neonates, in the first few years of life, it stays permanent, you know, for most of the life, and would have lots of sequelae. If one gets acute hepatitis B, there is a 90% resolution. There could be few episodes of fulminant hepatitis, and of course we have chronicity going on beyond 6 months, which may be, you know, ultimately gets resolved, would stay as asymptomatic carriers. Chronic persistent hepatitis or chronic active persistent may go on for a long period of time, with certain hepatic or non-hepatic sequelae. What is the definition of occult hepatitis B infection, or OBI? The presence of HBV DNA without the surface antigen, with or without the presence of HBV antibodies outside the acute phase window. The presence of HBV DNA in the liver tissue of individuals who test positive for hepatitis B surface antigen, regardless of the detection of HBV DNA in the serum, is defined as occult HBV infection. So either it is in your blood or in the liver tissue. In the absence of surface antigen, the DNA makes you occult hepatitis B. Occult is occult, of course, unless you get tested. In fact, the surface antigen is the one that is the screening tool. And in this subset that we are discussing, the surface antigen is just not there, and we have to really get the virus identified through the molecular ways by PCR and getting the DNA checked. HBV is occult infection, like the overt infection, can be transmitted through contact with blood, mother-to-child transmission, and unprotected sex. Of course, transfusion is one of the most important ways to get it as well. Hepatitis is common even after practicing the stringent donor selection criteria and screening the blood for surface antigen. So screening of surface by means of surface antigen is just not enough. This is because a considerable number of HBV infected donors remained undiagnosed if only surface antigen is used for screening. Serological patterns of OBI, surface antigen negative and HBV DNA is positive. So this is how you know about it. So 80% of those would have seropositivity of OBI, which is anti-HBC, positive or negative, plus minus anti-HBs. So either of the two, the core antibody or the surface antibody is present, and that is what the seropositive OBI is, which is majority of OBI, which is 80%, with higher DNA values. 20% of those would have the DNA in the absence of core antibody and surface antibody, and this group has lower DNA values. Schematic conditions leading to different seropatterns of OBI. Surface antigen lost after self-limiting acute hepatitis. Seropositive anti-HBC positive. Surface antigen is lost after, lots of years of chronic carriage. So in this group, do you have the seropositivity of anti-HBC? Anti-HBV never present, which is occult infection, means, anti-HBC is also negative in this group, and the surface antibodies progressively disappear over time. So in this subset, which is 20% or even less, you would have only the presence of DNA without the seropositivity. So as I already said, that the gold standard happens to be the analysis of liver tissue and blood for HBV DNA. HBV DNA in blood by nested PCR, real-time PCR, and transcription-based mediated amplification, the TMA. Anti-HBC is a less than ideal surrogate marker when HBV DNA measurement is not feasible. So, you live in a part of the world or in a society or environment where DNA is not readily available. You can actually assume, although it is not definite that this group would have, the DNA positivity, but you can still assume that this could be occult. So what happens if you have the HBV infection? You can have HBV reactivation under certain circumstances, and we'll discuss that. And you may have the development of HCC, and this is in one of those things that one has to keep in mind, and with severe disease progression going on. So, ladies and gentlemen, acute hepatitis B, occult hepatitis B infection is defined by the absence of surface antigen despite the presence of HBV DNA in the liver, blood serum, or peripheral blood mononuclear cells, irrespective of the presence of other hepatitis B viral antibodies and antigens. So this is how surface antigen again appears to be the core thing. It's negative and the DNA is positive anywhere in the body, in the blood, the mononuclear cells, or the liver. OBI poses a significant risk to those receiving blood transfusion or liver transplants because conventional donor screening with surface antigen and anti-HBC may yield serologically negative results despite the presence of HBV DNA. 20% of OBI infections are negative for all HBV serological markers, while HBV DNA is present, although the HBV viral load is often low. Detection of OBI can be challenging due to the extremely low levels of viral DNA, less than 200 international units per ml in infected individuals without detectable surface antigen. Despite numerous studies of OBI, its prevalence is unclear. This is due to the varying prevalence of OBI in cohort studies. Small sample sizes, a lack of appropriate controls, and varying assay sensitivities used in detection across testing centers. Underlying immunological and molecular mechanisms of OBI are not completely understood. Failure of assays to detect surface antigen in OBI infection is attributable to mutations of the S and pre-S genes, which may cause modifications of hepatitis B surface antigen antigenically. Mutations of the surface S gene may be responsible for negative results in individuals tested with standard assays. The exact mechanism by which surface antigen remains undetected is poorly understood due partly to difficulties of full-length DNA sequencing and full-length viral in OBI-infected individuals. Global studies of OBI show the prevalence is variable depending on the population studied, demography, and assay sensitivities. This is interesting because Anna and her colleagues published in this manuscript in 2011 from the HALT C group of hepatitis C, and the conclusion was that occult and previous hepatitis B viral infections are not associated with hepatocellular carcinoma in US patients with chronic hepatitis C. So what are the high-risk categories of OBI virological or clinical reactivation? The high-risk oncohematological malignancies under treatment, which is the rituximab-associated, the CHOP treatments, liver transplantation from anti-HBC positive donors, hematopoietic stem cell transplantations, the rheumatological diseases treated with biological agents or high dosage of steroids or prolonged treatment. Kidney transplantation, HIV infection, bone marrow transplantation, they are the intermediate risks. Low risk would be dermatological and inflammatory bowel disease treated with biologics, solid tumors treated with chemotherapy, organ transplantation other than liver and kidney, transarterial chemoembolization for treatment of HCC. So all these are groups where, of course, there has to be a collaboration between the treating physicians and the hepatologists concerned, because this subset population is at the highest risk for reactivation. And of course, this reactivation can produce disasters for this subset of population if it gets unlooked or overlooked. So collaboration is very important in this cohort. What are the therapeutic approaches for the prevention or the treatment of OBI reactivation? The ideal treatment for OBI should rely on a drug capable of eliminating the HBV cccDNA from the hepatocyte nuclei, possibly without killing the cells. Unfortunately, no such drugs are currently available, although we know, and we come to know, in fact, in later part of this symposium, that lots and lots of things are happening, and we would have help targeting even the surface antigen in the coming years. Consequently, we have to act to trying to prevent OBI reactivation, and above all, the development of acute hepatitis that may follow viral reactivation, and be aware that such prevention is life-saving in many cases. So what do I do? Of course, you have the HBV DNA, and you get a positive result, and you are consulted on one of those patients that may have problems for reactivation and all that. You need to prescribe what you have. It used to be LAM, good old days, but now we have the most effective treatment with tenofovir, alfenamide, and of course the other groups, even entecavir can be prescribed if tenofovir is not available in this cohort, before, during, and to continue after you have dealt with the clinical scenario. Hepatitis B surface antigen negative patients infected with S-escape HBV variants. The clinical virological features, including serum HBV DNA levels of these cases, are substantially similar to those observed in the different conditions of the overt HBV infection. The therapeutic approaches should be similar to that adopted in the typical HBV surface antigen positive forms, and patients undergoing chemotherapy and or immunosuppressive therapies should be treated with entecavir or tenofovir, which are the most potent anti-HBV nucleotide analogs, and very importantly, which have the highest genetic barrier. OBI patients with suppressed HBV replication and gene expression. This category of patients represent a difficult but frequent challenge for hepatologists. There are too many anti-HBC positive individuals in the world with the highest prevalence in HBV endemic areas to propose a preemptive therapy in all such cases. Undergoing immunosuppressive therapy is a difficult task. The collaboration between hepatologists and other specialists taking care of these patients, hematologists, oncologists, rheumatologists, and others, is often not sufficiently strong enough to guarantee the very narrow biochemical and virological follow-up necessary to identify viral reactivation early enough to start antiviral therapy and prevent acute hepatitis. So dear colleagues, in conclusion, the risk of acquiring occult hepatitis B virus infection is high in endemic regions of the world. Screening of at-risk patients with surface antigen is not enough, and PCR screening is recommended. Blood donors screening for surface antigen reduces but does not abolish the risk of transfusion-transmitted HBV infection. Thank you very much for your patience. Thank you.
Thank you very much, Professor Wasim Jafri. It was a pleasure having you. Once again, we would apologize for our initial hitches that we ran into due to technical problems. And now we are back on track, and it's the perfect time to start the second presentation of our session. The second presentation is going to be by Professor Robert Gish, and he will talk about to treat or not to treat HBV infection, immune tolerant and inactive carriers. Now, a little word about Professor Robert Gish is he's an adjunct professor of medicine at University of Nevada School of Medicine in Las Vegas, a clinical professor at the University of Nevada Reno School of Medicine, and clinical professor at the University of California Skaggs School of Pharmacy and Pharmaceutical Sciences. In addition, he's also the medical director of the Hepatitis B Foundation and medical director of Asian Pacific Health Foundation. Dr. Gish has joined the consulting faculty at La Maestra in San Diego to establish a liver care program in the federally qualified healthcare clinic. Dr. Gish, if you can come on, if you can take the screen, please. Over to you.
Greetings, my name is Dr. Robert Gish. I'm here to discuss the management of hepatitis B, what we used to call immunotolerant hepatitis B. I'll update you shortly on new terminology, to treat or not to treat. And I'm going to be advocating treatment for this 14th annual conference of PSSLD 2020. I wish I was there in Karachi, but I think many of you will be listening throughout the country and throughout the world. So welcome. Here are my titles and affiliations. I work throughout California and Nevada with a number of different programs, clinics, and I'm very active in the hepatitis B space. Here are my disclosures. Natural history of hepatitis B has been well defined. I'm going to, on this slide, talk about new terminology. Hepatitis B, E antigen positive chronic infection, is that high replication, low inflammation state that we used to call immune tolerant. We know these patients actually aren't immune tolerant. They're actually immune active, but they have a different form of activity. High quantitative S antigen, high quantitative E antigen, but you'll see that as a positive test, high DNA, and ALT often in the normal and often in the healthy range. Liver disease is active in the sense that there's active integration going on in those liver cells, but mild inflammation and often mild fibrosis. So even this table has a little bit of update that's needed. Once the ALT goes up, we call it chronic hepatitis, and we divide it into E positive and E negative. You can also have E negative chronic infection, E antigen negative, DNA's in a mid to low range, and ALT back in the normal or potentially even in the healthy range. This is breaking down these phases into a little bit more detail, and I'd like your eyes to go to that left box with the red. Let's go into that just a little bit more. High changes in immune activity, but low levels of cytokines. Few DNA mutations. Rarely would you find core and pre-core mutations happening. But I want to reemphasize active integrations are taking place. We also have chronic hepatitis, E positive and E negative. In some places, they call this an immune clearance phase. And let's go to the right side just for a moment, where we have S antigen loss, where we develop what's called occult hepatitis B, but CCC DNA persists indefinitely. Virologic and histologic features of chronic hepatitis B in patients with normal ALT. We have data here from US and India. In the left two set of boxes, you can see that the persistently normal ALT does have a significant number of patients with fibrosis, all the way out to stage 4. So it's very important in these groups of patients to be identifying levels of fibrosis either by biopsy or, better yet, non-invasive testing. FibroScan or elastography, which is across many different types of machines, may be best here because ALT often allows us to overestimate fibrosis when the ALT is super high or underestimate fibrosis when the ALT is in the normal or healthy range. Distribution of hepatic fibrosis among E-positive patients and E-negative patients with persistently normal ALT is highlighted on the left graphs. A little bit more data on this in the Asian American population on the left. It's a network of clinics in California and other locations. This is normal ALT under the healthy AASLD criteria. Now, this is 20 for women or 30 for men for this specific study. But there's a large number of patients with F2 or F3. That's 1/4 of those patients. Very important that F1 fibrosis is in the majority of patients. Advanced fibrosis on the right side by FibroScan in E-positive patients was published by Wong in Clinical GastroHep 2009, which also showed significant fibrosis on FibroScan in those patients with less than 1 times the upper limits of normal. Elevated ALT is associated with fibrosis in E-positive patients. But let's take that left group and amplify that just a little bit more. We're showing 10% of patients with normal ALT, that's 80 patients, with advanced fibrosis, that's a liver stiffness greater than 9 in the normal ALT patients. Probability of progression. So often we're talking about a one-time sampling, but also looking over a substantial amount of time, you can have progression to fibrosis here in over 12% of patients in that persistently normal ALT group. Liver cancer and other complications of cirrhosis and untreated E-antigen positive chronic infections are detailed here. So let's take a look at these individuals. The red line is those E-positive patients with normal ALT. Next on blue is E-positive patients, chronic hepatitis treated. So red, untreated, blue, treated. You can see the untreated patients in red have an increased incidence of HCC over time that's worse than treated individuals. So if you're going to treat and reduce risk of cancer, why not manage patients across the entire spectrum? Why not treat all patients? On the right side, you're also seeing in red untreated normal ALT patients with cumulative incidence of death or transplant that's higher than treated patients. Age at E seroconversion also correlates with risk of liver complications as highlighted on this graph. So you need to look at E status, when patients lost E, if you have that ability on your records, to also help you in the prognosis. This is inactive hepatitis B, being still at risk for hepatocellular carcinoma. This is low replication, so DNA measurable but less than 2,000 and normal ALT. These inactive hepatitis B carriers had a substantial risk or hazard of developing liver cancer over time as compared to control patients. Now let's talk about whether this immune tolerant is really an accurate term. So there is evidence for immune activity, so why call this immune tolerant? This is in the blue area. This is PD-1 positive CD8 T cells. It looks very similar to E-positive chronic hepatitis B patients. On the right side, you're looking at CD127 low, PD-L1, and CD8 positive cells, also over age. So here, over age, you're actually seeing increased immune activity. Evidence of liver damage in E-positive chronic infections is highlighted at the bottom. So you've got patients with chronic infection. They still can develop fibrosis. And you've got the Ishak fibrosis score highlighted on that left upper bar graph. And then collagen proportion area looks very similar to E-positive immune active and E-negative immune active. And this, of course, is using computer image access of paraffin-embedded tissue. Clonal hepatocyte expansion takes place in these patients who are E-antigen positive at normal ALT, what we used to call immune tolerant. Now, again, we're using that word chronic infection or high replication, low inflammation. But you're seeing that this clonal expansion takes place across all these different phases of disease. there is activity going on with hepatocytes in terms of clonal expansion. These presence of these hepatitis B specific T cell responses and the significant extent of HBV integration and cell mutagenesis across clonal hepatocyte expansion and the immune tolerant, what we used to call immune tolerant, now is chronic infection across the disease phases. I'd also like to have you highlight at AASLD this year to look at abstract 16 and abstract 22. In both of those papers, they're showing very clear evidence that early treatment with nucleotide analogs, specifically TDF, decrease the active expression of these integrated viruses. This is very provocative, but helps us support treating early and potentially treating all patients who are DNA positive. A little bit more on D integration. This is back in 2016. DNA integration occurs early. Relatively small number of biopsy specimens, but quite interesting details that are here. And integration sites are identified in these immune tolerant patients. Integration's early. Integration appears to be relevant and relative to liver cancer risk. So let's treat early and decrease integration and decrease active expression of integration. This integration and clonal hepatocyte expansion immune tolerant was further supported by the information here. The conclusion of this paper was withholding antiviral therapy in these chronic infection patients definitely requires reconsideration. Cumulative incidence of HCC and death or transplantation is highlighted here in this paper that we discussed earlier by Kim and Gutt 2018. Untreated patients do worse than treated patients. A little bit more here on hazard ratios for these individuals. So immune active phase treated was considered the reference amount, and immune tolerant phase or chronic infection untreated had a hazard ratio of 2.73, very similar to mild active phase patients who are untreated as well. So it looks like we have multiple directions pointing us to treating all patients with evidence of HBV DNA replication, irregardless of ALT and irregardless of fibrosis score. Antiviral therapy, now that we're advocating for this, does work in immune tolerant patients. This is an old paper, and of course, we're not using TDF and FTC together in our practice today, but it showed here that we could suppress HBV DNA very, very well in patients in intent to treat and per protocol. There's nothing about the ALT level or fibrosis that influences the drug effect on DNA replication and polymerase activity. A little bit more of this graphically, showing very, very good viral suppression in E-positive patients with normal ALT and high HBV DNA. Oral therapy for immune-tolerant E-antigen-positive patients has established indications. So this chronic infection, or what we like to call also high replication, low inflammation, these patients are often undergoing immune suppression. They may be getting hepatitis C DAA therapy. They may be a pregnant individual who we are trying to prevent maternal to child transmission. Hepatitis B has a number of extrahepatic manifestations, including low quality of life and social stigma and what's called self-stigma. For healthcare workers, by lowering HBV DNA, we can reduce infectivity as well as other clinical settings, including family and marital environments. Many factors affect hepatitis B progression. So you have a patient with hepatitis B, viral loads 800, ALT 36, just above the upper limits of healthy, and they have metabolic syndrome. We know that markedly amplifies HCC risk. What about co-infection with HIV, Delta, or hepatitis C? What about smoking, which enhances cancer risk, or alcohol, or aflatoxin? These are all issues that make us think about treating essentially every patient, because we have very little control over many of these external factors that increase cancer risk. By reducing HBV DNA levels to undetectable, cancer risk can proportionally be decreased in many of these clinical environments. These articles, published here by a number of these different investigators, show this management and prevention of HCC development. Immune-tolerant patients, the natural history is not as well defined as you would think. Hepatitis B Research Network, it's very important to look at their data and how many patients fall into these gray zones or gray compartments. Progression of liver disease and liver cancer are not rare complications. Compliance to wait and see strategy is quite low. Effective and safe nucleotides are available at a low price at generic levels in many countries. There's many established indications to use nucleoside and nucleotide therapy that we listed earlier. Think about now, we are dropping age thresholds to treat less than 30, different levels of fibrosis down to evidence of fibrosis, thresholds such as family history of liver cancer or specific genotypes or the presence of core or pre-core mutations. To treat more people and to get to global hepatitis B elimination, we really need to be thinking about treating all patients who are HBV DNA positive. A little bit more on arguments. Patients with normal ALT may have fibrosis, so do a thorough assessment for hepatic fibrosis for those individuals. Viremia levels change over time, ALT levels change over time, and it's back to risk of transmission. We can decrease transmission by suppressing virus. Old management, treat only patients that they fulfill specific guidance. New management, treat all patients who are DNA positive unless there's a specific reason not to treat. Recent literature has helped support these issues. I'd like you to look to this Kennedy paper in 2017. Recent literature is helping us guide our guidelines. Immune tolerant patients allow for full consideration of treatment. Consider our new terms: chronic infection, high replication, low inflammation. Assess liver cancer risk also by biomarkers. We have 3 good liver cancer biomarkers. Consider doing a calculated GALAD, G-A-L-A-D score in those patients also to trigger this treatment process. ALT, consider what's healthy or normal. It's the virus, as our infectious disease colleagues have taught us over time. Thank you very much for having me at this 14th annual conference of the Pakistan Society for the Study of Liver Disease 2020 in Karachi. And of course, we are throughout the world. Please stay safe. I look forward to seeing you in country as soon as possible.
Thank you very much, Dr. Robert Gish. It was an enlightening presentation, and we take the message very loudly and clearly that we are going to treat every hepatitis B patient that we find. So coming up next is a name that is not only known in the world of humans, but also in the world of viruses. We have Professor Mario Rizetto, and he's going to shed light on the treatment of hepatitis D, any ray of hope. So a little introduction of Professor Mario is that he's the Professor and Chair of Gastroenterology, Division of Gastroenterology, Department of Medical Sciences, University of Torino, Italy. Mario Rosetto is an Italian virologist who in 1977 first reported the hepatitis D virus as a nuclear antigen in patients infected with hepatitis B who had severe liver disease. He graduated in medicine and surgery at the University of Padua in 1969. He was awarded the King Faisal International Prize in Medicine in 1985, the Robert Koch Prize in 1987, the William Beaumont Prize of American Gastroenterological Association in 1988, and has the Hans Popper Award in 1992. Dr. Rizetto, please come online and take the screen. Thank you very much.
PEG interferon alpha is the only approved therapy for chronic hepatitis D. However, this therapy has limits. The limits are shown here in the table. In particular, a high rate of relapses post-therapy has been observed. In the HIDTI-1 study, only 6 of 14 patients who achieved SVR maintained a virological response. Relapses have occurred as late as 9 years post-therapy. PEG interferon lambda is credited to have less side effects than PEG interferon. Current therapeutic strategies against the HDV are targeted to deprive the virus of functions critical to its life cycle provided by the HBsAg. 3 strategies are now under evaluation. 1. Blocking HDV from entering hepatocytes. Bulevirtide, formerly Mirclex-B, a myristoylated synthetic lipopeptide corresponding to the pre-S1 sequence of the HBsAg, blocks the sodium taurocolate co-transporting polypeptide receptor for HDV. 2. Preventing the assembling of HDV particles. Lonafarnib hinders the prenylation of the large delta antigen, a post-translational modification necessary to its interaction with the HBs antigen. 3. Preventing the export of HDV variants with nucleic acid polymers. NAP2139 appears to inhibit secretion of HBsAg from hepatocytes. Only preliminary data are available for lonafarnib therapy. The drug has been used in combination. 19 chronic HDV patients were treated with oral lonafarnib 50 milligrams and ritonavir 100 milligrams twice daily, together with interferon lambda 180 micrograms weekly for 24 weeks. At end of therapy, the median HDV RNA decline was 3 log per ml, and 7 patients, equal to 37%, became HDV RNA negative. Bulevirtide, formerly known as Mirclex, is the drug for which there are more data available so far. The pivotal study for bulevirtide has been MIR-203. In this study, 4 groups of 15 patients each were given PEG interferon alpha alone, or 2 mg Mirclex-B plus PEG interferon, 5 mg Mirclex-B plus PEG interferon, or 2 mg Mirclex-B alone. The patients were treated for 48 weeks, followed by 24 weeks follow-up, to a total of 72 weeks. The virological results are shown in this figure. On the left, you can see that the decline of HDV RNA with the combination therapies was much more profound than the decline seen with PEG interferon alone or with Mirclex alone. However, at suspension of therapy, during the follow-up post-therapy, HDV RNA has relapsed in all groups. ALT declined consistently in all groups during therapy, but again, they relapsed after suspension of therapy during the follow-up. Note on the right part of the figure, under the arrow, right arrow, that at the end of the follow-up, 24 weeks after suspension of therapy, a proportion of patients treated with only 2 milligrams Mirclex still maintain normal ALT. What is the current therapeutic scenario of bulevirtide and lonafarnib in chronic hepatitis D? Though the HBsAg clearance is the ideal endpoint of HDV therapy, this goal was seldom attained with both drugs and is unrealistic in clinical practice. Certainly, bulevirtide and lonafarnib are active against the HDV, but PEG interferon alpha remains the backbone to optimize treatment. The virologic response after 48 weeks of combined therapy is mostly transient. This means the longer duration of therapy are required. How long, we still don't know. This raises a critical tolerance problem, in particular versus the side effects of interferon alpha. Would PEG interferon lambda be more suitable for therapy? As the clearance of the HBsAg is unrealistic, and the clearance of HDV RNA is not a reliable endpoint, and no other hard endpoint of therapy is at hand, it has been suggested to rebalance the therapy of HDV to a more pragmatic approach. In other words, to prioritize the clinical aspects, normal liver enzymes and improve liver function over the very logical results. On this conclusion, and based on the observation that bulevirtide and lonafarnib induce a 2-log decrease of HDV RNA in a sizable proportion of patients, and this was mostly associated with ALT normalization, it has been proposed to use in clinical trials as a surrogate marker for initial treatment efficacy a decline of 2 or more logs of HDV RNA at end of therapy, on the assumption that compounds achieving this antiviral effect can be an important adjunct to other drugs with different antiviral mechanisms in improving the management of chronic hepatitis D, provided they possess also a reasonable safety profile. This unorthodox and perhaps debatable compromise is intended to justify long-term therapies for maintaining a clinical and biochemical remission over time. However, a prolonged and clinical and eventual surveillance is needed to confirm the therapy is controlling HDV and to rule out late hepatitis relapse. To further determine the role of bulevirtide alone in the therapy of chronic hepatitis D, the MIR 203 study has been extended to include an arm, shown here in blue, of 10 milligrams bulevirtide plus tenofovir. Tenofovir was given only to prevent relapses by the hepatitis B virus, so this arm is meant to be synonymous with 10 milligram bulevirtide alone. The blue arm that you see has been compared to 10 milligrams bulevirtide plus PEG interferon alpha, with the same schedule, 48 weeks of therapy, 24 weeks of follow-up, for a total of 72 weeks therapy protocol. You see from the figure that the percentage of patients treated with 10 milligram bulevirtide who reached the primary endpoint of undetectable HDV RNA was significantly higher than the 6.7% of the patients who reached the same goal with 2 milligram bulevirtide. However, when considering the 2-log reduction or undetectable HDV RNA goal, the percentage of patients who reached this goal was not significantly different in the bulevirtide 10 milligrams arm versus the 2 milligram bulevirtide arms, with 46.7% in the former group and 33.3% in the latter group. You can see in the lower left part of the figure that HDV RNA declines in the 2 milligram bulevirtide group and in the 10 milligram bulevirtide groups were similar. On the right part of the figure, you can see that 24 weeks post-therapy, ALT remained normal in 5 of 15 patients treated with 10 milligrams bulevirtide, equal to 33%. In the original 203 study shown before, ALT had remained normal in 3 of 15 patients, equal to 20%, who were given bulevirtide 2 milligrams. There was no change of serum HBsAg with bulevirtide also in the study. While the data of the MIR 203 studies have not yet been published in extenso and therefore difficult to analyze, bulevirtide has nevertheless obtained conditional approval on July 2020 in the EU with the commercial name Epcludex for the treatment of chronic HDV in HDV RNA positive patients. The dosage is 2 milligrams once daily by subcutaneous injection as monotherapy or co-administered with a nucleoside-nucleotide analog for treatment of the underlying HBV infection. See, the European Medicine Agency assessed 31st August 2020. Bulevirtide 2 milligram would appear to control chronic hepatitis D only in a minority of patients, and whether it can maintain long-term clinical inactive HBV infections in patients who clear serum HBI RNA but remain HBsAg positive is unknown. The clinical dilemma is underlined by the instructions for use. Though the optimal treatment duration is unknown, treatment should be continued as long as clinical benefit is evident. However, what is intended as clinical benefit is not been determined and not been specified yet.
Dr. Murillo, thank you very much for an excellent presentation once again. And with this, we move on to our next talk. The next talk is going to be by Professor Cihan Yurdaydin from Turkey. He will talk about new biomarkers of chronic hepatitis B infection. Little words about Professor Cihan. He is WGO past president, professor director, Department of Gastroenterology and Hepatology at KOC University Medical School, Istanbul, Turkey. He specialized in internal medicine at the University of Ankara School of Medicine, Medical School, Turkey, after gaining his medical degree from the same establishment. After a year of national service at a military hospital and 2 years of one state hospital, he returned to the University of Ankara to specialize in gastroenterology. He has published more than 150 articles and his papers has received more than 6,500 citations. He has served in the scientific committee of EASL between 2000 and 2003 and as educational counselor from 2013 to 2015. He has also served the World Gastroenterology Organization at various positions and was the president of his organization between 2017 and 19. With this, I would like Professor Cihan to take the screen, please. Professor Cihan, are you there? Professor Cihan, unfortunately we cannot hear your voice, but we can see you. We are trying to find a way to get it sorted. In the meantime, if we have a little time with us, so let's talk about. I would like to hand over the mic to Professor Zagam Abbas for a few comments on the previous lectures, if he can.
So far we have heard from Professor Wasim Jafri, an occult infection, OBI, occult hepatitis B infection, is an important topic, and only hepatitis B screening is not the answer. We have to screen with nucleic acid, perform the nucleic acid testing, as he has rightly mentioned about the occult infection that may be there. So he discussed more about S-escape HBV variants and how can we prevent transmission of hepatitis B occult infection. Professor Robert Gish again discuss about the immunotolerance. If Professor Gish is still there, may I ask a question, Professor Gish?
Professor Gish, if you are there, please can you turn on your camera? Professor Zagam, I would like to share a very interesting observation. Yeah. Back in 2014 and 14 or 13, when I was training with Professor Arshad Kamal Bhatt, one day while talking about recommendations of not treating patients with normal ALT but with a viral load, he said in those days that one day the recommendations are going to come that we are going to treat every patient of chronic hepatitis B regardless of the ALT levels. And now in 2020, I see that coming true almost.
So, Professor Gish, you have give much evidence that we should treat immunotolerant patients with patients who have the high viral load but almost normal ALT. But only problem that we see is that we have been treating such patients. The resistance is a problem. Like we have come across tenofovir resistance, like viral load start rising again, and ALT starts rising again also in these patients. As you know, we have only two drugs, entecavir and tenofovir, and if we get out of two one drug resistant, then that would be a problem in real term when the patient is actually needing more treatment rather than in the immunotolerant phase. What do you say about that?
I think the incidence of TDF or TAF resistance is probably in the 1 per 1,000 patient range. As you know, in the large licensing studies for both of these medications, there was no resistance identified using even, I would say, complex molecular characterization. So if your benefit for these patients is decreased infectivity, decreased stigma, decreased liver cancer risk at least, I think the benefit far outweighs any risk of that resistance. And of course, if you get TDF or TAF resistance, you can add entecavir to that patient's case, and in 99% of patients get full viral control in my experience.
Thank you. Professor Mario, very interesting talk as always. It's always a pleasure to listen to you. You talked about bulevirtide and lonafarnib, and the conclusion of your talk is that whatever you do so far, whatever the new drugs are becoming available or under trial, and they are only to suppress the viral virus, but the long-term sustained response is not there. And the new consensus that you mentioned by Professor Cihan is also here, 2019 paper that shows that 2-log reduction is sufficient in the future clinical studies. So what do you say? There are some studies about nucleic acid polymers, and they claim that they are able to eliminate hepatitis B surface antigen also. And then there was some claim about the NESVAC people, the nasal hepatitis B vaccine, and there were some trials that. What is your opinion about nasal hepatitis B vaccine and nucleic acid polymers, Professor Mari?
The paper on Polymer 2139 came out in 2017. However, the data, the basic data, were published, I think, 3 years before. Since then, so we must assume since 2014 to 2015, nothing more has come on the issue of 2139 in clinical terms of therapy on chronic hepatitis D. So it's a bit perplexing, frankly, because if you have something so good that clears H delta, HDV RNA, and HBsAg in 50% of the patients, in a minority of the patients treated, 12 patients at a time, you would expect some follow-up at this stage. We wait and we see, but so far I cannot tell you anything. I think if I ask you the same question, what will you conclude? Let's see if we have a follow-up to this study. As the vaccine one, same story. Now, the big problem that I personally feel with all the studies on therapy that have been proposed, outside or apart from the initial proof of concept study, there's been no extended publication on the therapeutic final effect. So we have data only from abstracts, and we have to reason on abstracts without any other data. This is difficult because of this reason, it's conclusion from abstracts are very limited.
So, are we ready, Professor Cihan?
Dr. Mario has completed his thing, so we are on? Okay. So unfortunately, we are having some technical issues on the side of Professor Cihan. So we need a few minutes to sort that out. In the meantime, we move on to our next talk as we are a little time bound. The next talk is by Professor Anna Lok from USA, and she will talk about current and future of HBV treatment. A little introduction of Professor Anna Sook Fong Long is that she's the MD Professor of Medicine, former Director of Hepatology, Program Assistant, and Dean for Clinical Research at University of Michigan, USA. She has served as Associate Editor of Hepatology from 2001 to 6 and Senior Associate Editor of Gastroenterology from 2011 to 12. She's currently the President-elect of the American Association for the Study of Liver Diseases. Professor Anna, if you can please grace the screen. Thank you very much.
morning. First of all, I'd like to thank the organizers for inviting me to participate in this very important meeting. My topic today is on current and future treatment of chronic hepatitis B. These are my financial disclosures. As you all know, we currently have multiple approved treatments for hepatitis B, including interferon and the oral antivirals. We rarely use interferon these days, and among the oral antivirals, we focus on entecavir and tenofovir because of the low risk of drug resistance. These oral antivirals are very potent in suppressing HBV DNA, resulting in a 6 to 7 log decline in HBV DNA within 1 year of treatment. Pegylated interferon has weaker antiviral effect. Nonetheless, pegylated interferon does result in a higher rate of HBs antigen loss, although these rates are shown for overall, and the rate of S antigen loss is much lower in patients infected with non-A genotypes. Among the oral antiviral, the rate of S antigen loss is very low, even with continuous treatment for up to 7 to 10 years. Despite the low rate of S antigen loss, antiviral therapy has been effective in reducing clinical outcomes. HCC, decompensation, as well as liver-related mortality, particularly in patients who have achieved S antigen loss, where you see a further decline in HCC incidence compared to patients with suppressed virus but remain HBs antigen positive. We know that the effect on HCC is not immediate, and within the first 5 years of treatment, there is continued linear increase in HCC. However, studies from Europe show that after the first 5 years, the graph appears to slow down. And in the right hand, where you see among the cirrhosis patients, the graph appears to flatten out and indicating that these patients have a lower risk of HCC. And the risk of HCC after year 5 appeared to be mostly in older people, those with cirrhosis at baseline, in particular, those with low platelet count at baseline in year 5 and continued high liver stiffness at year 5. Thus, current treatment has been shown to have potent viral suppression, reduces liver inflammation and fibrosis, prevent progression to cirrhosis and liver failure, as well as decreased risk of liver cancer. And at least with the nukes, the safety profile is excellent. However, there are limitations because they do not eradicate cccDNA or integrated HBV DNA. And the rate of S antigen loss is very low, particularly with non-A genotypes. Thus, for most patients, a long duration of treatment is required in order to maintain clinical benefit. And the risk of HCC persists, albeit at lower rate. Because current treatment does not cure hepatitis B, we're not recommending treatment for everyone. There are, however, clear-cut cases in which treatment should be initiated now. These are patients with life-threatening liver disease, regardless of HBV DNA or ALT level. There are patients with pulmonary hepatitis B, severe exacerbations of chronic hepatitis B, or decompensated cirrhosis. We also recommend treatment for patients at high risk of liver failure or liver cancer in the near future. These are the patients with compensated cirrhosis, and again, regardless of HBV DNA or ALT level. We also recommend prophylactic antiviral for surface antigen positive patients who will be starting immunosuppressive therapy, and surface antigen positive pregnant women with high HBV DNA, more than 200,000 IU per ml, starting in the late second or third trimester of pregnancy, not to further reduce maternal to child transmission. For patients with no cirrhosis, we recommend treatment for those at high risk of progressive liver disease. Essentially, we recommend treatment for patients who are in the immune active phase, either E antigen positive or E antigen negative. Currently, we do not recommend treatment for patients in the immune tolerant or the inactive carrier state, largely because available treatment is not very effective in these patients. Well, many have questioned whether that is wise, to observe these patients and not to treat. Well, the issue is not so much whether we treat them or not, but whether we treat them now or we continue to monitor them and treat them later when indicated. And what would be those indications? We know that in patients with chronic hepatitis B, the degree of virus replication and liver inflammation changes over time. So treatment would be started when replication or the liver inflammation becomes more active, as well as when the evidence-based guidelines changes as a result of more data, and certainly when more effective treatments become available. A big debate now is when to stop the NUC therapy. These are the different guidelines. For patients with cirrhosis, all the guidelines essentially say continue treatment and do not take the risk of virological or clinical relapse. For patients with no cirrhosis, in antigen positive, we recommend treatment until antigen seroconversion and undetectable HBV DNA for at least 1 year of consolidation therapy, maybe even longer. For antigen negative patients, the ASLD guidelines still recommend treatment until S antigen loss. But we've just mentioned that that rate occurs very rarely, indicating that majority of the patients will continue treatment for life. In recent years, APASO as well as EASL guidelines have recommended that in selected patients, after 2-3 years of suppressed HBV DNA, we may consider stopping treatment. And these are based on data suggesting that stopping treatment might result in increased rate of S antigen loss. This is some data presented at an EASL meeting earlier this year. This is a randomized controlled trial in which patients who were antigen negative with no cirrhosis prior to start of treatment and have completed at least 4 years of NUC therapy were randomized to either stop treatment in arm A or to continue treatment in arm B. What you can see is that at week 96 after treatment was stopped, arm A had a 10% rate of S antigen loss compared to none in arm B. Note, however, that a third of these patients did develop ALT flare, although none of the patients experienced decompensation in this particular trial. More recently, at the ASLD meeting, only a couple of weeks ago, there was another study. This is a retrospective study, but of much larger number of patients, 1541, from 12 different centers in North America, Europe, as well as Asia, who stopped NUC treatment. They were all antigen negative at the time of stop of treatment, and none of them had calculated interferon within 12 months of stopping the NUC. 88% of them were Asians, and majority of them were antigen negative at the start of NA therapy. What you can see here is that at 4 years, there's a cumulative rate of S antigen loss of 14%, much higher than what had been reported in patients who are continuing to receive NUC, although there was no control group in this particular study. Interestingly, Caucasian race was the only independent factor of HBs antigen loss after NUC was stopped, with a hazard ratio of 5.8. In this study, however, 15 patients did experience decompensation, and 12 of them died, of which 9 were liver-related. And half of the patients had to resume treatment by month 48. Well, because of all these concerns that we need to keep patients in long-term treatment with a very low rate of S antigen loss, there's been a lot of questions as to whether we can achieve cure of hepatitis B. Well, unlike hepatitis C, eradicating hepatitis B is more complicated, largely because of the presence of cccDNA, which is a very long half-life, and is currently not affected by NUC treatment and only partially reduced by interferon therapy. We'll also understand that with the life cycle of hepatitis B, cccDNA can be replenished not only by entry of new variants, but also intracellular recycling of the nucleocapsids. Hepatitis B can also be integrated into the host genome, making eradication of integrated HBV DNA very difficult. And we know that patients with chronic hepatitis B have impaired immune response. Thus, when we talk about a cure for hepatitis B, ideally we would like to achieve sterilizing cure, but this is not going to be achievable in the foreseeable future. Rather, we focus on realistic functional cure, which is very similar to patients with chronic hepatitis B with S antigen loss either spontaneously or with current treatment. These will be patients who become S antigen negative with or without anti-S. HBV DNA would be undetectable and neoantigen negative. However, HBV DNA will still be present in the liver, although transcriptionally not active, and is certainly integrated HBV DNA. There may be residual liver disease, but is no longer active, and fibrosis will regress over time. The risk of HCC would also decrease with time. Well, how are we going to achieve that? We're going to need multiple drugs attacking different targets of the HBV life cycle. Currently, we have boxed in red, interferon, and the polymerase inhibitors, which only have limited action. But we currently have multiple drugs in clinical trials. Boxed in blue, the entry inhibitors, RNA interferons, nucleocapsid assembly modulators, and assembly and secretion inhibitors. And I'll show you a few examples. First, RNA interferons are the antisense oligonucleotides. How do they work? Essentially, destabilize or decrease the action of the HBV RNA, both the pregenomic RNA, thereby blocking further virus DNA replication, and the messenger RNA, thereby blocking virus protein production. In so doing, they reduce HBV replication.
Dr. Cihan, Dr. Anna is there.
A very large randomized trial of prednisolone, pentoxifylline, and placebo in alcoholic hepatitis. And so this group has been using that data to kind of generate even more information about what happens to these folks.
Hello?
Yes, Dr. Anna, can you hear us?
Yes, I can.
We thoroughly enjoyed your presentation, and we would like to thank you for your time. So can we have some questions? If we
Anna, may I ask a question? Can you hear me?
Sure.
Oh, okay. Thank
Yes.
you. Thank you very much. So we just heard from Professor Gish, and he convinced us that we should start treating immunotolerant patients. So what's your opinion about that? Whether this would become the part of the guidelines of AASLD in future, or you don't see that there is much evidence that it should be included in AASLD guidelines in future?
I do not expect it will be included in the ASLD guidelines in the near future. I do not dispute that patients with very high virus level should be treated. We do not want patients to have circulating high virus level. The problem is with the current treatment, they're not very effective. And even if you put them on the nukes, you cannot suppress the HBV DNA to undetectable level. You might be able to drop it down to low levels, but in many patients, they still have low levels, and there is no E antigen loss and there's no S antigen loss, which is very well demonstrated in the paper that Henry Chen published in Gastroenterology a few years ago of TDF versus TDF plus FTC.
Thank you.
So it is something that we would like to do, give patients treatment. But the question is, we need to have more effective treatment before we provide a widespread treatment, because it's difficult to justify putting all young patients on lifelong treatment.
Dr. Anna, let me take the liberty of asking you a question. What about those patients who who did not respond to interferon therapy for hepatitis D, but they have a negative DNA level for hepatitis B, and they are child class A or child class B serotics? In the absence of the hepatitis B DNA, with the treatment failure of hepatitis D, would you recommend using nucleotide analogs in this patient?
I'm not sure I understand. The HBV DNA is suppressed, and you're talking about hepatitis delta?
The HBV DNA is suppressed, but we tried treating the hepatitis D virus with interferon, but it failed somehow. And patient is an early child class A serotic. And while waiting for the newer drugs for hepatitis D to arrive, is it rational to continue with nucleotide analog treatment in this patient?
Oh, yes, because the patient has cirrhosis, and therefore, if they have cirrhosis, regardless of HBV DNA level, we would want to have them continue on a nuke, because we know that if we stop the nuke, the virus may relapse, and that can cause a major flare. If the patient doesn't have cirrhosis, it may be a different story.
So if, let's suppose he does not have cirrhosis, what would you recommend then?
Well, if the patient doesn't have cirrhosis, and the patient had received nuke treatment and the DNA is suppressed, then it would be dependent on whether the patient was e antigen positive to begin with. Because the current guidelines are, if the patient does not have cirrhosis, was e antigen positive, and now has undergone E0 conversion, and has completed at least 1 year of consolidation treatment, you might consider stopping. Now, if the patient was e antigen negative to begin with, and now the patient has been on treatment for 4 or 5 years with suppressed DNA, as you know, the current trend is to explore whether taking patients off nuke would actually result in a higher rate of S antigen loss versus continuing them on nuke.
So you would do that.
So in selected patients, I would, but you have to have a discussion with the patient, and the patient has to be willing to agree to very close monitoring.
Yes, this again highlights the importance of sitting down with the patient and discussing and explaining to him that what we are going to do and whatever we are doing is in the best interest of his of the patient himself. Moving on from here, we would thank you, Dr. Anna, and we would like to give we would like to see if we are connected to Professor Cihan. Professor Cihan, if you can hear me, can you come online, please?
Hi. So. There was a question.
Yes, Professor Gish, let me read the question again for you. Professor Shahab Abid wants to ask you that can we achieve functional cure by short-term interferon treatment in patient with inactive disease?
So most of the data, by the way, it's a very good question. Most of the data with pegylated interferon and even standard interferon remotely was in patients with active disease, at least elevated liver enzymes, though at that time we weren't as well defined at DNA levels because of limits of assays, and also our S antigen data is a little bit thin. So I would say right now treating patients with normal ALT with interferon would not be indicated. And the only place that interferon has right now is, in my opinion, is in patients with low quantitative S antigen. So one thing to think about, and of course, Dr. Yurdaydin will probably discuss quantitative S antigen. I think that's an ideal test to have baseline in all patients. And that helps you monitor them off therapy. It helps you monitor them during therapy and maybe select patients for interferon therapy. And can I make one more comment about my proposal to treat all patients?
Yes, please do.
Great. So one is, if we don't bring all patients into treatment, how are we going to get to elimination? That's an important question, and that's one of the factors that came into the strong position I took in my talk. Also, there's this whole issue about stigma, self-stigma, social stigma, and discrimination that's not in any of the guidelines. So the guidelines take this evidence-based approach. They look at studies, look at patients in those studies, but they're not looking at the patient in general. So I want to look at the virus, I want to look at the patient, and I think stigma is a very important part of why to treat all people. Infectivity is another issue. If we had tuberculosis, you wouldn't count how many TB, mycobacteria is in their sputum before you decide to treat them. You know, they're positive, you treat them. For most infectious disease, we treat infectious diseases as they are present, not based on some viral load. We know that lowering DNA decreases HCC risk. Anna made a great point that we're not as effective in viral suppression, but the glass is 3/4 full, not 3/4 empty or 1/4 empty. I see viral suppression, even if we don't get to viral clearance, because our drugs have very rare events of resistance, that lowering virus is a very effective way to approach these patients.
Hello?
And now we're learning all about stop therapy, but you can't stop therapy if you don't start therapy.
Hi.
So these are all considerations.
Yes, that's a very valid point about the infectivity of the patient. Even if the patient has a low viral load and is not under the criteria for treatment, he's a potential risk factor for his family and for his surroundings. Is that correct?
Yes, I think that's a strong consideration.
So moving on from here, there's another question by Professor Shanil Kadir. He says that occult hepatitis B is a headache.
Benden bağlanabilir misin? Ben bilgisayar getirsem bu ne? Buradan tekrar bağlanırsın, ben mi getireyim?
Evet.
Ha?
Evet.
Özgür bir daha ara.
Yes, the question is by Dr. Shanil Kadir, and he says that occult hepatitis B is a headache in a country like Pakistan, where screening is still not common and cost is an issue. So how do we incorporate the HBV DNA checking into the screening process, and should we only think about DNA level in high-risk patient groups? Dr. Gish?
So my comments on OBI is, first off, Dr. Jafri's talk was fantastic. It really is going to bring this to the forefront. And in a resource-limited country, you can't check DNA with nucleic acid testing on every patient. So if I have a core positive patient only, and they have elevated liver tests, I would think about checking DNA by PCR in that patient. But all core positive patients don't need DNA testing if you have limited resources. For seronegative OBI, again, cryptogenic liver disease, unexplained elevated liver enzymes, that would be a patient where I would think about checking a DNA. But I wouldn't check a DNA just randomly in a general population or in core positive patients. And remember, if a patient's core positive and surface antibody positive, the chance of having occult hepatitis B infection is much lower because those patients have attained immune control. I want to make one final point, is that word natural immunity, we hope, is completely banished from everybody's lexicon. We understand now that core antibody persists basically lifelong. And the reason that exists or persists is cccDNA is continuously making low levels of core antigen. So core antibody equals cccDNA. Core antibody indicates risk of reactivation. And people who have core antibody don't need to be vaccinated. That's also something that we need to remove from the algorithms. There's been no published articles about a clinical benefit of vaccinating core positive patients. If you're going to spend money, spend your time looking for OBI, not vaccinating to get a cosmetic surface antibody boost.
By the way, do you hear me? Do you hear me?
Do we have Professor Jafri here? If Professor Jafri, if you can hear us, what is your take on this?
Okay.
Your presentation is on screen right now. It's yours for the taking.
Can I start my talk?
Absolutely.
Okay. I hope I can finish my talk. It's on new biomarkers of chronic hepatitis B virus infection. Why do we need biomarkers in chronic hepatitis B? In comparison to other viruses, the natural history of hepatitis B is a little bit complicated for outsiders. So we need it for differentiation between phases of HBV infection to have a professional language between professionals to understand each other. And we also need it for surrogates of treatment efficacy, because what we have as goals of treatment is prevention of progression of liver disease, development of hepatocellular carcinoma, death from liver disease. We want to prevent it, but we cannot wait until this is prevented. So we need surrogates of treatment efficacy. And we have that in the form of HBV DNA, we have that in the form of surface antigen clearance, but surface antigen clearance is very difficult. But in terms of nucleoside analog treatment, we have a very efficient surrogate marker of treatment efficacy. But with new treatments coming on, we need new biomarkers, and I'm going to talk about new biomarkers for hepatitis B. Now, in terms of phase of chronic hepatitis B, we all know them, this slide, and I will go through the new biomarkers during different phases of chronic hepatitis B virus infection at the end of my talk. Now, in terms of new biomarkers, I want to start with hepatitis B core-related antigen. Hepatitis B core-related antigen contains 3 proteins encoded by the pre-core gene. These are core antigen, E antigen, and the small core-related protein called P2020CR. They share a 149 long amino acid sequence, and this is detected by core-related antigen serological assays. The core-related antigen can be measured by an automated assay, commercially available automated assay. And it correlates well with HBV DNA, the core-related antigen, but less well with surface antigen. And this can be shown here. It correlates well, correlated antigen, I'm sorry, I just have to. Sorry. Hepatitis B core-related antigen correlates well with HBV DNA as shown here with an R value of 0.8, both in E antigen positive and E antigen negative chronic hepatitis B. But with surface antigen, there is a correlation, but the R value is much less. And hepatitis B core-related antigen correlates also with intrahepatic viral markers, such as total DNA, cccDNA, pregenomic RNA. And as you can see, for core-related antigen, the R values are quite high. So there is a significant, really significant correlation. Now, I'm sorry for this terrible slide, but I want to switch things now. I want to switch to inactive surface antigen carrier and its identification by means of hepatitis B core-related antigen. As you know, Brunetto et al. Had a long landmark paper on inactive surface antigen carrier where she was able to diagnose the inactive carrier state with HBV DNA and quantitative surface antigen levels. But that was in genotype D HBV patients. And another study done in the Far East showed that the diagnostic accuracy of surface antigen in combination with HBV DNA was not as high with genotype B and C patients. Now, what this study shows is that they confirm that hepatitis B surface antigen alone or in combination with HBV DNA has a rather low diagnostic accuracy. It's around 59% or 62%. But correlated antigen, less than 3 logs. And by the way, I have to say that correlated antigen has a detection limit of 100 units per ml, but detectability is considered if it is above 1,000 units per ml. So in that context, 3 logs is somehow the threshold between detectable and undetectable correlated antigen. And patients who have less than 3 logs of correlated antigen plus an HBV DNA less than 2,000 units per ml have a diagnostic accuracy in terms of inactive carrier state diagnosis of 87%. And that applies for genotype, a group of patients composed of genotype A, D, E, F, and H. And so correlated antigen may be valuable also in the context of the diagnosis of the inactive carrier. Another side of correlated antigen where it may be helpful is as an alternative to HBV DNA for treatment eligibility assessment. Now, this is important in low resource settings such as Africa, where HBV DNA is expensive and difficult to do, and correlated antigen may cost 50% or even 10% of the cost of DNA. And this study has shown that, as you can see, that correlated antigen in terms of the correlation with more than 2,000 international units per ml of HBV DNA has an area under the curve of 0.88, which is much higher than surface antigen or E antigen. Or for I mean, of course, with a cutoff of 3.6 logs. And with a cutoff of 4.8 logs, this has an area under the curve of 0.92 for diagnosing HBV DNA more than 20,000 international units per ml. So basically, we are replacing by certain cutoffs the HBV DNA as a diagnostic marker with correlated antigen and with a much cheaper price. So this is something which should be considered. And this, what I mentioned about diagnostic capacity of correlated antigen, has been also compared with algorithms such as the WHO algorithm for diagnosing the active chronic hepatitis B patients in low resource settings. And their area under the curve is 0.73 when you use the ASLD criteria for treatment indications. And this model with correlated antigen plus ALT has area under the curve of 0.90. So this appears to be fine. Correlated antigen appears to also predict spontaneous e antigen seroconversion, as can be seen here. In this study, by multivariate analysis, correlated antigen at week 28, or the delta decline from baseline to week 28, with these cutoffs, less than 4.9 logs or more than 2 logs in terms of delta decline, had an area under the curve of 0.9, more than 0.9, and very high positive and negative predictive values for predicting spontaneous e antigen seroconversion. And not only spontaneous e antigen seroconversion, but treatment-induced e antigen seroconversion can also be predicted by correlated antigen, here shown for PEG interferon in the e antigen positive settings, where the specificity is higher. It's not very high for the sensitivity of 93% for correlated antigen, but it's still higher than, for example, surface antigen, quantitative surface antigen levels. And the same holds true also for the e antigen negative setting. Now, correlated antigen appears to be also important in the context for deciding on nucleoside analog cessation in chronic hepatitis B. This is a study in Japan done in 2014, and the Japanese Society of Hepatology had this in their guidelines. Basically, what they have shown was, if you had at the time of nucleoside analog cessation, if you had a surface antigen level less than 2 logs or exactly 1.9 logs, you had a score of 0. And if the correlated antigen was less than 3 logs, you had again a score of 0. With a score of 0, you had a 80 to 90% chance of sustaining the good outcome after stopping treatment. So very low risk of reactivation. And if you had a score of 1 to 2, the reactivation probability was 50%. And this is something which was put together as an algorithm in terms of stopping treatment in 2014, and it was in the Japanese guidelines for treating hepatitis B. Now, comparison of patients with relapse versus non-relapse after nucleoside analog cessation. Again, in e antigen positive, e antigen negative chronic hepatitis B, if you look, is there any marker, demographic, hematological, biochemical, which predicts relapse versus non-relapse? Basically, very little, except end of treatment surface antigen, barely significant, but end of treatment correlated antigen, 3.7 logs as the cutoff, had a significant predictive value in terms of bio-relapse or non-relapse. And basically, in this study, a very recent study, they did a multivariate analysis and found age quantitative surface antigen levels, correlated antigen levels, AST, and tenofovir use, and they put together a scale B score, which is defined here, and which can be used as predicting safe nucleoside unlock cessation. And the functionality of the scale B score is shown here. The area under the curve is very high in terms of predicting relapse or surface antigen clearance. It appears to be much better than the area under the curve of the Japanese Society of Hepatology guidance I mentioned to you based on the 2014 data. And as you can see, based on the score, you can predict surface antigen clearance quite fine. Now, another biomarker, HBV RNA. HBV RNA is basically pre-genomic RNA. It's the template for protein synthesis and is transcribed from cccDNA. So it indicates presence of cccDNA transcriptional activity, and it gives us a very good estimation of the cccDNA reservoir size. It can be detected by in-house PCR assays, but now there is also a commercial assay available by Abbott, and it shows a very good correlation with HBV DNA. Shown here, especially in e-antigen positive, you have a very good correlation with HBV DNA. In e-antigen negative chronic hepatitis B, the correlation is not so good because of integrated DNA contribution. Similar to correlated antigen, HBV RNA also appears to predict e-antigen seroconversion in e-antigen positive chronic hepatitis B. And low or undetectable HBV RNA at nucleoside treatment discontinuation predicts good outcome, as can be seen here. This is the relapses. These are the non-relapses, which show, again here, undetectable HBV RNA. The likelihood of relapse is very low, clinical relapse, and the likelihood of clinical relapse in detectable cases is much higher, close to 40% on long term. Another new biomarker, another semi-new biomarker is quantitative surface antigen, and quantitative surface antigen reflects also the transcriptional activity of cccDNA in e-antigen positive. This is the case also to a lesser extent in e-antigen negative chronic hepatitis B, where the contribution of integrated DNA has to be considered as well. Lower levels are associated with better immune control. There are commercially available assays. Assay correlate strongly with each other. And this slide is a study from Europe versus Asia, and basically they have similar results. They can differentiate between different phases of chronic hepatitis B infection. You have high levels in immune tolerant, so-called immune tolerant cases, and in low replicative inactive carriers have the lowest levels, and the others are in between. E-antigen positive and E-antigen negative active chronic hepatitis B have levels in between. And this is the study I mentioned about diagnosing inactive carrier state with DNA and quantitative surface antigen levels. We know all that. What I just want to underline is that it was suggested to have a diagnostic accuracy of 94% in the study from Far East with genotype B and C HBV. The predictive diagnostic accuracy was much less. Low surface antigen predicts surface antigen clearance. We like to see that the surface antigen levels in a patient with chronic hepatitis B is below 100 international units per ml, because we can say you are going to lose clear surface antigen. In 10 years, about 50% will clear surface antigen. Even if the patient has less than 1,000 international units, that's also a good sign. Now, in terms of nucleoside unlock discontinuation, there was a recommendation of expert Chang, Liao, and Hadzianis in 2015, published this data based on their systemic review. They said that patients who have low S antigen, in particular if the S antigen is below 200 international units per ml, you can more or less safely discontinue nucleosome treatment if the patient is not cirrhotic and if the patient has received at least 2 or 3 years of hepatitis B virus treatment. Another new biomarker, an old biomarker, anti-HBC, which was used in Italy semi-quantitatively and is now back again on the market as quantitative marker. It's a marker of HBV. It's core antigen-specific immune activity. It shows that it's an immune assay, may reflect strong immune response against HBV, the levels of anti-HBC in serum parallel ALT levels and hepatic inflammation, and high levels may predict e-antigen seroconversion, but high levels may also predict, in the case of nucleoside analog cessation, clinical relapse of the patient of chronic hepatitis B. Finally, one new marker is the quantification of large and middle proteins of surface antigen. As you know, surface antigen circulates in serum as non-infectious subviral particles, mostly in 1,000 to 200,000 fold excess relative to the virions. And as we know, the surface antigen is composed of large, middle, and small parts. And it's the large hepatitis B surface antigen which binds to the NTCP receptor on the hepatocyte to enter hepatocyte. And measuring large surface antigen makes sense. It makes sense that it may be more important than measuring surface antigen. And in this study from Germany, basically what they have seen was that in the inactive carrier state, large surface antigen was compared to e-antigen negative chronic hepatitis B diminished. And in their study, they suggest that large surface antigen can be better used as for differentiation of different phases of hepatitis B, but more studies are needed in that context. Now, this is the summary of what I have said in terms of phase of chronic hepatitis B. In the e-antigen positive infection phase, which is the so-called immune tolerant phase, we have low titers of anti-HBC, very high titers of core-related antigen and HBV RNA. In the e-antigen positive hepatitis phase, ALT is, of course, increased. DNA is a little bit lower compared to the immune tolerant phase. Anti-HBC is now high. Core-related antigen and HBV RNA are high, but not as high as in the first phase. And this, in the inactive carrier phase, anti-HBC is low, because there's no activity, inflammatory activity. Core-related antigen and HBV RNA are of intermediate levels, and so on. Now, I want to summarize what I said. New biomarkers, I try to convince you that they contribute to the management of chronic hepatitis B. They will continue to do that. They affect other hard endpoints such as HCC as well, which I have not mentioned because of time constraints. There are also immunological or fibrosis markers as well, which I did not mention because of time constraints. But these new biomarkers are important because they may serve as primary or secondary endpoints in new drug development studies. The devil is in the detail. Thank you very much.
Thank you very much, everyone. With this, we announce the closure of this session, and I would like to hand over to Dr. Amna Subhan for the next symposium. Thank you very much. Signing out.